Session, the first participant, Dr. Vinoj Murugesan. Quality of life of caregivers and patients undergoing maintenance hemodialysis, a single center experience.
You have got 8 minutes to present and 2 minutes for discussion.
Yes, sir. Good morning, sir. Good morning, everyone. I'm Dr. Vinoj from Madras Medical College, representing it. And I'm here to present a paper on quality of life of maintenance dialysis patients and the caregiver burden that their caregivers undergo and its effect on their quality of life. Kidney failure impacts the quality of life of patients due to its effect on social and economic functioning. The nature of its disease and the therapy and the complications all matter to it. We intended to study the quality of life of those patients and the caregiver burden that these patients undergo and the determinants of the quality of life that these patients have. This was a single center cross-sectional observational study conducted at Madras Medical College. All clinically stable patients were included in our study, and those who had undergone at least 3 months of maintenance hemodialysis at our center were included. We had a dynamic center also, but this one was collected in our static center where the patients come for an OPD hemodialysis, and those are clinically stable. The collection of data was done and the assessment was done by using the EQ5D tool, which caters to 5 modalities. One is mobility, self-care, usual activities, pain, discomfort, and anxiety. Based on these, a score of 1 to 3 was given. And the other page, this was converted to the local language in Tamil, and then it was questioned via in a questionnaire format. And there was a thermometer scale by which the patient assessed their visual analog scale at the state of health at that point of time. This was the Zaret Caregiver Burden Index, which was asked to the patient in a 22 questionnaire format, which was converted to the local language also. Coming to the demographics, the total number of patients included were 98. The median age was 45 years, and male comprised 70% of the population. The median dialysis vintage was 42 months, and the serological status, 79% of them were negative, 14% of them were HCV positive, and 5% of them were HIV. The representing them as shifts, first shift was 45%, second was 38%, and the third was 17%. The axis left BC was the predominant axis. 23% of them were diabetic and 80% of them were hypertensive. Educational status, 43% of them had completed primary education, whereas 9% of them had no formal education. Native kidney device, hypertension was 33% and unclassified was 27%. 67% of them were married and 25% of them were unmarried and 6% of them were divorced. In employment status, 86% of them were unemployed, whereas only 14% of them were employed. Coming to the main part, the mobility score and self-care score, a score of 1 was given by 72 and 71% of them, giving that the green one shows the M1 score. The mobility and self-care had higher levels of mobility and self-care, whereas in activities and pain and anxiety, the blue one represents the people who given a score of around A2, P2 and A2. So pain and anxiety were the most affected domains of our EQ5D. Whereas in the anxiety component, 20% of them, that is 18% of them represented around severe levels of anxiety. This is the visual analog score histogram depicting that the median visual analog score was 70. This is a scatter plot depicting the visual analog score distribution across various ages. We determine the variables determining the quality of life across all shifts, across twice weekly and thrice weekly, across male and females. While comparing the 3 shifts, there was no statistical significance in all 5 domains in mobility, self-care, pain, anxiety, activities. Whereas the second shift patients tended to have a higher level of activities when compared with the total population. And the first shift patients, they tended to have lesser levels of anxiety when compared with the total population. This was statistically significant. Influence of gender on the quality of life. This one had stark differences, whereas women reported low levels of mobility, self-care, activities, pain and anxiety in all 5 domains of the categories when compared with their male counterparts. Determinants, the median visual analog score showed that 70 was the median visual analog score when compared to 85 of the general population. So significantly low in our maintenance dialysis patients. And pain and anxiety were the most affected domains. And women undergoing dialysis experienced significant limitations in mobility, self-care, activities and pain. Coming to the caregiver characteristics, I was 98. Gender distribution, interestingly, was 67% were female, probably representing the population which were male in our dialysis patients. The median age was 42. The relationship predominantly was spouse, being a wife, and husband being 9. Educational status, 51% of them completed their primary education, 22% completed their secondary education. 83% of them were married, and 46% of them were unemployed. It was quite high. Depicting, this is the Zaret burden score. We scored it up to, we separated them based on 20 to 40 and more than 40, and the median Zaret score was 30. Distribution of the caregiver burden. This green represents the percent of population who were female patients. That is, the patients were females in those population. And those people who had more than 40, the attenders who had more than 40 Zaret scores, predominantly catered to female patients. And women were around 50%, 40%, and 30% in the more than 40. We compared it across 3 groups, that is less than 20, 20 to 40, and more than 40. And it was found that median age was a significant factor for caregiver burnout, and patient being female was high significance. And interestingly, people who had completed their primary education had more amounts of caregiver burnout, whereas those who had completed their secondary education tended to have lesser degrees of caregiver burnout. The significance not known. And also, when the patient was an earning member of the family prior to the onset of the disease illness, those caregivers tended to have lesser degrees of caregiver burnout. And the caregiver vintage was directly proportional to the caregiver burnout. And we tended to improvise this, and we saw that the caregiver burden amount, which contributes towards the quality of life of the patients, it did significantly affect the activities and anxiety scores of the patients whose caregivers had higher degrees of burnout. Results: caregiver burnout was significantly higher in caregivers more than 45 years of age and female patient caregivers, and those who had only completed primary education, and longer dialysis vintage of the patient. And caregivers who had a Zaret burden score of more than 40 had direct impact on the anxiety and activity domains of the patients. Caregiver patients who were earning members prior to the disease had lesser degrees of burnout. Conclusions: median visual analog scale based quality of life on patients on maintenance dialysis was lower when compared to the median general population. Higher levels of restriction in the domains of pain and anxiety. Women had higher degrees of restriction in the on all 5 quadrants. Caregiver burnout was significantly higher in caregivers more than 45 years of age, female patients, and longer dialysis vintage. And these Zaret scores directly affected the quality of life in the activity and anxiety domains of the patients. So inclusion of the 4-stage, we did a 22-stage Zaret questionnaire. There is also a short form of it, of the 4-stage Zaret questionnaire, and the visual analog scale in routine maintenance dialysis patients, and intervention by psychiatry department in the caregivers who have Zaret burden more than 40 could improve the quality of life in the anxiety and activity domains. Thank you.
And so, Doctor, that is a very interesting paper. Now, looking at the quality of life of dialysis patients, did you find any difference between those patients who are getting dialyzed twice weekly and thrice weekly?
It was not statistically significant.
It was not. Did you look at their cardiac function? Did you look at their ejection fraction or some measure? Because the quality of life would have something to do with the physical activity can be correlated with their.
Yes, sir.
But then you haven't looked into it.
We should have.
Okay.
In males or female patients, who the psychiatric illness was more common in males or females? Depression, anxiety.
Patients' anxiety was more in males, sir. Females had lesser degrees of anxiety.
And caregivers?
The caregivers who were caring towards female patients had higher levels of anxiety and levels.
So all these patients took psychiatric consultation, they took some psychiatric medications, they improved, something of that kind?
No, sir. No, sir.
Okay. So it's open for discussion.
Yeah, it's very interesting, wonderful work which you have done. But I believe this is done in a government setup,
Yes,
I
sir.
believe.
Yes, sir.
So you know that most of the financial burden of the family has been taken care of as the dialysis care is concerned.
Yes, sir.
So do you think how this particular work is going to be useful for a nephrology community or for society? The kind of work which you have done,
Yes, sir.
how it will be useful is the end result of this one. Second issue is I found that I think in your population, the males, I think males are more predominant. I
Yes, sir.
believe.
Males are predominant,
Males
70%.
There is only 30% of females.
Yes,
isn't
sir.
it? So that what is the reason for this kind of difference?
Yes, sir. Thank you for the question, sir. The first question was how it will cater that we get to know that our patients and our caregivers are under immense levels of stress and burden, so that the quality of care that we give to them could improve on the long run, and we don't get burnt out in the long run, and acknowledging that they are burnt out. One thing, sir. And the other thing is we could incorporate a short form of questionnaire into our maintenance dialysis questionnaire, which we attach in our front of our paper, so that we can know the amount of burden that the caregivers are undergoing, and it relates well to our patient's psychological status also. And the second question, sir. Yes, sir. Probably both are equally affected by the disease, but the mentality of our population towards giving care for the female patients could be less. We need to improve on that frontier yet in our country probably. There is no, maybe there is no disease predilection for males in our disease actually. So probably both are affected equally, and the amount of care that we give for both of them should vary probably.
Do you think it will be useful for healthcare planning, like healthcare planning, financial planning, and especially the insurance?
Yes,
for the national level? If you
Definitely.
want to plan for an insurance or something, work will be useful.
Okay. Thank you, sir.
Congratulations on doing a very good paper. So often we tend to disregard or ignore the caregivers. So thank you very much for looking into that aspect of dialysis care.
Thank you.
My question to you is, you have used certain tools to analyze the different parameters that you wanted to analyze. Have these tools been validated? When you said they've been translated to your native language,
Yes,
when these tools are translated to your native language,
Yes, sir.
have they then been validated? Is the question.
Yes, sir. Thank you for that question, sir. Actually, this EQ5D tool, which we had used for assessing the quality of life of patients, was translated by the EQ5D Europol group themselves, sir. They have it in various around 170 languages, and we mailed them, and they replied us in our own language. They have it in our own language. In Malay, they have several languages for that, sir. And it's validated, surely, sir. Thank you.
Last question. Did you find any impact of shift on the psychiatric manifestations?
Yes, sir. That's why we actually thought that it would definitely affect them, those having in the third shift. But then we found that only the anxiety domain of the first shift patients, those who reported an A3 level, that is a severe levels of anxiety, was low when compared with the first shift patients. So probably the first shift patients are less anxious, probably.
Have you made any suggestions?
Awesome.
Okay, so that was an interesting paper and a very interesting discussion. So let's go to this next paper
Thank you.
by